So I think we can recommence for our next session. Unfortunately, Martin Tick has been unable to make it to Brisbane, so we'll only have two speakers in this session. But our first speaker, Maria Vasileiadi, will cover some of Martin's content. And the title of Maria's talk is it's Concurrent ITBS fMRI for Target Circuit Engagement in Clinical Research. We'll then have another speaker, Teresa, and we'll hold off on questions until the end of the session. So over to you, Maria.
Good, okay, so good almost afternoon, everybody. So today, as Andrew mentioned, I'll be covering both my own work and the collaborative work that I've done with Dr. Martin Tick in Vienna, which is where I did my PhD. And I'll be focusing on the target circuit engagement in clinical research with examples from clinical trials that I'm currently involved in at Sunnybrook Hospital in Toronto. So you'll get some examples from treatment-resistant depression mostly. Good. So let's start with the clinical context. So every fifth person will experience depression at some point in their life. And it's one of the leading causes with that of disability worldwide. So while we have several pharmacological and psychological treatment options, many patients still do not respond and do not achieve full remission rates. And in the worst cases, of course, depression can be fatal. So it's very important that we find proper treatment for everybody. And so there is a growing interest in non-invasive brain stimulation, and of course, TMS has been now FDA approved for years as a rapid-acting treatment for depression. But despite its growing use in all our developments, there is still a lot we don't understand about this method. And that is especially regarding of how it exactly works and why it works in some people and not in others, as has been mentioned before in the previous talks. So over the past 20 years, the TMS protocols have evolved significantly. So the first major approval being in 2008 with a 10 Hz repetitive TMS protocol, 3,000 pulses per session delivered at over almost 40 minutes or a long time over several weeks. Then in 2018, Bloomberger and his colleagues showed that ITBS, which is a much shorter 3-minute protocol, was just as effective. So this reduces the treatment time significantly. And then, of course, more recently, we have accelerated protocols like the Stanford Neuromodulation Therapy that delivers multiple sessions per day, which shrinks the total time to under a week. So we've made a lot of progress on efficiency, and ITBS seems to be the protocol to be used for that. So other than the different types of stimulation protocols, we also have the cortical target that we need to think about. So as has been mentioned a few times before, we have resting state networks in the brain, and we can show brain networks without any task. And this opened actually the door to identify functional targets in the DLPFC based on the connectivity rather than the anatomical landmarks that have been used in earlier days. This is basically on the DLPFC and the SGACC axis, which we'll be discussing way more detail this afternoon. So we can map these areas to the individual functional connectivity, and it has been shown that the more that we personalize these targets to the person's functional connectivity, the better the treatment outcome. So we take this into consideration into our treatment protocol. And as has been mentioned several times before, when we think about developing an effective TMS treatment plan or therapy plan for depression, there are a few core components to consider. So we need to select the right stimulation pattern, as I said before, the right stimulation target, and finally the dosage. So the stimulation intensity, how many pulses per session, how many sessions per day. So there's so many parameters that we can consider. And understanding and optimizing each of these elements, I think, is key to improve our treatment response. And that is, I think, where combined imaging can help us to refine the protocol. So with concurrent iTBS-MRI or TMS-MRI, we can directly observe the brain modulation during stimulation, rather than just pre- and post-treatment changes. And we can actually sort of validate if the intended network that we are targeting is engaged. And this is crucial to understand the mechanisms lying underneath TMS and improving our targeting methods potentially as well. Now, we've also spoken before about state dependence. So TMS-MRI also allows to measure, to assess whether stimulation effects are different based on the current cognitive or brain state during the delivery of stimulation. So there's a lot of parameters and questions that we hopefully can answer with iTBS-MRI. Obviously, it has its caveats, but I think we're on a good way with this type of method. Now, it's not as easy as it sounds to just put a magnet in a magnet. There's several concerns that come with that, or considerations, I must say, that we can address to the best of our ability. So when setting up an iTBS or TMS-MRI protocol, there are two main technical challenges. So it's safety and artifacts of imaging, right? So on the safety side, we use non-magnetic coils like the McVenture B91, so is non-ferromagnetic material outside. But even then, the magnetic field causes some mechanical stress, so we need very sturdy coil holders, as you can see in the top right, to hold our coil in place on the targets, on the participant's head. And then there is the artifacts that we need to consider. So some are static, just from the coil being inside the scanner. And here, a smart RF coil design can help. Others are dynamic, so RF noise along the cable, leakage of currents, or timing issues between TMS and fMRI. And to avoid these, we can use filters, relays, and most importantly, we need to get the timing right. So as I said, timing is crucial. If the TMS pulse has a temporal distance, so this is the acquisition of one slice in K-space. So we follow along K-space, along the arrows pointed out there. And A, B, and C are three different time points of where I can potentially put my stimulation pulse, right? So if I put it in A, so with a delay of 35 milliseconds, we see both in image space on the top and in K space, we see a certain artifact, right? So we can see that we're imaging a spherical phantom, and we can see there is no spherical phantom there. If we stimulate a little bit later, we see that the artifact shifts the other way. And still we can kind of now see that there is a spherical component to this. But if we wait until the EPI slice is completely acquired, we have actually a stimulation pulse just after. So this gives us a nice spherical component. So imagine that being the head, we get like artifact-free imaging if we get the timing exactly right. And I want you to appreciate how small the timing differences are here, right? So we need to leverage the exact timing that we can do with the TMS pulses, because we have a very high temporal resolution delivering these pulses, and we can use that. So here again, about timing. So we can have three different approaches to timing. We could stimulate at any time and then sacrifice a single slice if we're not so interested in that part. This is an option you could do. Then we could stimulate between different acquisition volumes, so in certain acquisition gaps. But you have a bit of a delay there, so this might be about 300 milliseconds. Or we can really use and optimize our MRI sequences combined with our TMS to precisely allow stimulation between slices. So what is the output, right? So you stimulate during image acquisition. People are in a rest state. And we can see here a key example of what a concurrent TMS-MRI scan can reveal. So this was an activation pattern during stimulation of the left dorsolateral prefrontal cortex. And each slice here represents an actual brain section showing the bold signal increase during ITBS. So the brighter the color, the stronger the signal change. So what is important to highlight in these slides is that we're not just seeing activation in the DLPFC, which is highlighted in these blue circles, but we're seeing also responses in connected areas. So you see a more widespread whole brain response. So this can tell us that the stimulation isn't acting in isolation, right? It's not just at the stimulation site that we see this increase, but actually the signal travels further along the brain. So it's modulating a network, and this type of physiological readout is what we mean when we talk about target engagement. So without this concurrent imaging, we wouldn't know if the stimulation actually doing what we hope and is targeting the brain circuit at a circuit level, right? Because we have all these theories about the SGACC and the DLPFC, and we optimize our targets based on resting state fMRI, which is acquired before treatment, and now we can see the online response to stimulation. So now that we've kind of established that ITBS can induce a measurable activation in key brain regions that we are interested in during the stimulation, the next step would be to connect those neural changes to clinical relevance. So we can do that by correlating these bold activation patterns that we see with outcomes like a treatment response, a symptom reduction, and patient-specific factors of any type of interest. Taking all of that in mind, I want to guide you through the results of our clinical trial at Sunnybrook. So I'll briefly show you our protocol, the key methods, and some early findings that highlight how the approach I just advocated for can inform us both on the mechanistic understandings and on the clinical outcomes. So this is the outline of our clinical trial. So we recruited and screened each participant. They underwent a baseline MRI first, including both structural and resting state fMRI. And they then completed so the baseline was obviously to define personalized stimulation targets based on functional connectivity with the SGACC. Then a week later, we completed a session of interleaved TMS fMRI where we applied both active and sham ITBS. I will come back to that a bit later, while acquiring the bold signal to assess the target engagement in real time. So following this, the patients went on to receive a course of accelerated ITBS treatment with 600 pulses per session and 8 sessions per day across 5 consecutive days. So that's a total of 40 sessions. So we measured the clinical assessments at baseline, immediately post 4 weeks and 12 weeks. So we have kind of a nice spread of their depression development. And on the right top, you just see some basic characteristics of our sample. So what I would like to point out is that the total mean number of treatments is about 9. And I think the illness duration, 21 years on a mean. So these are very highly treatment resistant patients, okay? This is not the first rodeo of trying to treat their depression. They've been through a lot. That's just to take that in mind. Okay. Good, so here you can see our setup. So on the left side, you see my PI, Dr. Sean Nestor, and our PhD student, Chris Popel, who are demonstrating our setup as we have it in Sunnybrook. So we're using the neuronavigation tool to place the coil right on the target that we want, as Christian just explained before, with the 2 MR-compatible targets. And we use a single subject SGACC connectivity to guide our positioning. And we also use E-field modeling to optimize the trajectory and make sure that we get the highest electric field in our target region. So this is a little bit more detailed picture of our setup. As you can see, it's not the easiest or most comfortable looking, but actually it's quite snug and comfortable, I can say from experience. So we use the base of a 64-channel head coil, as you can see. Then we place the subject head in a vacuum pillow, so you can kind of suck the air out, so the pillow kind of holds the subject really nice in place. So it also takes in the TMS coil, so everything is really snug, because a big issue with MRI is motion. And with TMS, as people might have experienced, it's not the most comfortable, especially ITBS to the left heel PFC can activate some nerves and some muscle traction, so you might move a little bit, so we want to have them as tight as possible, still comfortable, obviously. We then added a 4-channel special coil. So that's a carotid coil that you can see in gray, the small one. This is normally used for neck imaging, but we found that if you place it right on the forehead, we get a really good signal in the SGACC, so we enhance our signal there. And then we hover over another 4-channel body coil that is kind of a flex coil that kind of arches over the head. So we really try and get the best signal in the whole brain, as well as in our target areas, which is the SGACC. So as I mentioned before, we have a sham-controlled stimulation paradigm. So sham controls is kind of related to the placebo in pharmaceutical trials. So as you can see, underneath the TMS coil there's a small spacer. So this spacer is about 2 centimeters thick, and it's just plastic. This means that when you stimulate, the actual electric field will not penetrate through the brain and will not induce any response in the underlying regions, but will still give the same sensations of the coil being present. So that is a whole other avenue, is sham-controlled TMS and what's the best way to do this. But this is how we decided to go forward, and that is our setup. Good, so this is how we decided to do the timing. So we were, with our precise timing, able to do a full clinical protocol during imaging. So these 3 minutes of ITBS that the people are getting outside of the scanner as a treatment, we were able to translate that and put that into the MR scanner. We have 10 bursts of 3 pulses at 50 hertz delivered in a 2-second train, exactly between the slices. So this allows for continuous imaging without any artifacts. So this will give us a real-time view of how the brain responds to one session of ITBS. On the right top, you just see, again, the functional target based on the resting state connectivity. So this is just, in short, our data analysis. We use a voxel-wise linear regression and some high-pass filtering. We modeled the stimulation events as with a boxcar HRF, and included also the motion regressors, which is a very important thing to do to account for the movement during the scans. So we did an ROI-based analysis. So we looked at specific regions because we have a very strong hypothesis for this. So we looked at the DLPFC. We actually calculated the E-field masks, and we thresholded them at the 99th percentile to get like a very specific ROI. You can see an example for a subject on the top right. And then we looked at the SGACC as well. This we took also from the individual segmentations of an atlas. We then related all these time series within these 2 ROIs to the MADRS depression scale, which is a standardized scale to measure depression severity. So first of all, these are our clinical responses after the ITBS treatment. You can see on the left-hand side that the average lies above 30 pre-treatment, goes down immediately after treatment, and stays down for the remaining. You can see the significance is also up there. Good. So here on the left side, we see that the acute response within our deep brain target, it being the SGACC, is significantly different between our sham and active conditions. That means that we did do something different and might have actually created a good placebo there. And more specifically, so in the active condition, the response is more negative and possibly reflecting an inhibition of brain activity. And more interestingly is that the acute response of the SGACC, so you can see that on the x-axis, which is relative between active and sham, is proportional to the connectivity of the DLPFC resting state connectivity, okay? So that means the more negative the connectivity between these targets is, the more negative the acute response of the SGACC is here, which has been suggested before, and we've confirmed this now in our patient cohort. So further, we can see that, so on the y-axis now, it's the MADRS score. So a greater reduction in depression is on the left bottom. And we can see the SGACC ITBS response, again, relative active to sham on the x-axis, where on the left side it's more negative. And we can see that the more negative the response is in the SGACC, the lower the MADRS scores, so or the higher reduction in MADRS scores. So we have this significant correlation between SGACC response and MADRS change, which kind of supports our idea that the SGACC could be a biomarker for early treatment response. So I've now only shown the 0-day post here. And this highlights the potential of using this neural circuit engagement that we have here to guide personalized TMS treatment to see where you can get the most negative response that might actually be the best way to go. So maybe a TMS-MRI session before every treatment session can give us a lot of information that you wouldn't get otherwise. So now we know from this clinical trial that SGACC engagement predicts treatment response in a way, but even if we hit the right target, the stimulation intensity we apply could determine whether we actually engage the whole network effectively or not. So currently the way that we dose stimulation is based on the motor threshold and derived from the primary motor cortex, but it's unclear whether this approach actually generalizes well to other areas like the DLPFC, which has a completely different cytoarchitecture and connectivity than the M1. So then we ask, is there a dose-response relationship in the DLPFC or in the DLPFC SGACC network? And if so, could this be used to personalize stimulation parameters? So I'll first show you the dose-dependent TMS-MRI study that we did in Vienna together with Dr. Martin Tick. So this study was designed to characterize individual dose-response profiles using concurrent TMS-MRI in healthy participants, I must say, okay? So participants underwent a preparation session where we measured their motor threshold, identified the DLPFC target as such, and then we used actually a customized TMS-MR coil array, as you can see here. So the setup was a little bit different than what we use in Sunnybrook. And then TMS was actually delivered at 4 different intensities based on the motor threshold. So at 80, 90, 100, and 110% of the motor threshold. And this is a 10 hertz stimulation. So mind you, before I showed you ITBS, this is a 10 hertz protocol. And here we also use a different type of TMS-MRI where we applied the burst between slices rather than each single pulse between a slice. So here we can see the group results of this study. So on the left top, you can see the 80% motor threshold. We are now focusing our attention to the left DLPFC in this study. And you can see it increase from 80 to 90 to 100. And 100 and 110 look very similar. So you can kind of group them in lower and higher intensities, right? So there seems to be, from these images only, kind of a linear response. However, when we look at the single subject DLPFC dose response curves, we see that here each panel represents one participant. and separate plots for left and right DLPFC for each participant. And we can see there is a lot of variability that we see in these subsets. So while some subjects like number 1 and 3 show a clear linear increase in bold activation with higher intensities, others like 4 and 5 kind of have a flatter or even non-monotonic response curve. And this highlights a key issue, right? So the dose-response relationship is not uniform across individuals. And in some, 100% might actually already be optimal. And in others, 110% might increase the effect that you get. So this altogether suggests that one-size-fits-all dosing may not be ideal for neuromodulation in depression. So again, these were healthy subjects. So how does that look like in patients? So we repeated this design now also in Sunnybrook with our depressed cohort that I showed you before. So we performed the interleave TMS-MRI at the left DLPFC, same as I showed you before, but instead of ITBS, we now did 10 Hertz RTMS at different stimulation intensities, completely similar to the one that I just showed you in healthy individuals. So here we see the acute brain response at 10 Hertz. Mind you, the setup, physical setup of the experiment was a little bit different, where we had the TMS coil was squeezed in between the head and the RF imaging coil, which means that we have kind of a dropout on the left DLPFC side. So we have no signal there, and therefore probably also no bold response recorded. However, we know that the left and the right DLPFC are highly connected, so we can take the right side here as a proxy of the activation. And you can see that actually at 110%, it's absent in the right DLPFC, whereas 100% again, similar to with healthy participants, was actually a pretty good measure of getting a right DLPFC activation pattern there. So this is just to compare the sham. In sham, we did not find anything in the DLPFC. However, you do see a lot of activation that is mostly acoustic activation. Just there's a lot of noise if you put the TMS on in the scanner. When we look at the group response in the SGACC, we can see that sham, it's all positive. So these are the contrast estimates within this ROI. And with the 10 Hertz, we're actually getting a negative SGACC response, which is what we want. However, it's not very linear. It seems, again, like 80 to 90 do something different than 100 and 110, but we cannot really separate all of these single values together. So, mind you, this is 30 participants together. If we then look at the prediction of these percentages, these different intensities for the MADRS change at 5 days post, we can see that 80% does not predict. The 90% also does not predict. So on the y-axis, it's the MADRS change. On the x-axis, it's the SGACC response. 100 also not. And then 110%, actually with a really good significance, and you can see the line already, that the acute brain response during TMS with 110% actually predicts the treatment response. And I forgot if I mentioned it before, but the ITBS stimulation that we did during treatment was with 110% of the motor threshold. Now, this is different protocols, right? So this is 10 Hertz versus ITBS, but with the same intensity. So this is a very promising finding, I think. But again, as you saw with the healthy participants, there's also a lot of heterogeneity in the individual dose response in the SGACC for the patients. So we can see a group on the left and on the right, and I'm not sure if you can, from my previous story, identify left and right, but so just to describe, on the left side, you see some positive values on the left two panels. Then next to it, you see a negative response at 80% and 100%. On the right side, you see a group that has only negative responses, with 100 and 110 being the highest. And so these are the non-responders to the treatment, and these are the responders. Did we not stimulate the right target, maybe for these people, where we actually got positive values for the SGACC? Was the treatment intensity too high for these individuals? These are all questions that we can kind of try and tease apart using this method, right? So we can try out different things. Maybe we should have treated this person at 80% of their motor threshold. Maybe it was too high, and there's a different type of curve. With this data, I just want to show you that it's not a straightforward answer with this dose-response story, okay? We have a lot of individual variability, and I think that it's really worth looking into this, because this might explain why not everybody responds to the same intensity of treatment. Good, so dose matters, but it's not the same for everybody, is kind of the message from here. And the whole brain analysis showed the intensity-dependent modulation of the SGACC. We saw a trend for the dose-response relationship at 110%, but then if we tease it apart and we look at the individual patients, they vary considerably. So this inter-individual variability suggests that we really need personalized dosing strategies. Okay, but what about the single person? What about the intra-individual variability? Because we're not the same every day or every hour of a single day. So this is where Martin and I came up with the chronometric TMS-MRI to test for state dependency, which is a topic that we have also discussed before. So when we talk about state-dependent effects of TMS, we're referring to the idea that the brain's current state can influence how it responds to TMS. And this is clinically relevant because TMS may be more effective when delivered during specific brain states, such as during an active engagement, like Hamid also said, during addiction and exposure therapy, for example. But in depression, that might be a task rather than rest. By combining TMS with fMRI, especially while the subject is performing a certain task, we can actually leverage the high temporal resolution of TMS with the spatial resolution of fMRI to see where those effects land in the brain. So this approach allows us to precisely map how stimulation affects specific neural circuits during clearly defined cognitive processes, okay? And we can overcome some issues with the sham control as we have an active condition in two different states, so that might be a better control condition to each other rather than adding a spacer in between. So here's, for example, some of the evidence that, for example, on the left side is a working memory task combined with RTMS, which then leads to a stronger clinical response. And on the right side, when we compare TMS treatment courses in patients that were instructed to focus on either positive or negative thoughts, we can see that the negative group failed to respond. So state does something to the stimulation, or the stimulation is received in a different way in different states. So in our experiment, we had 2 sessions. Session 1 was for planning. So we had an anatomical scan, a resting state scan, and an NBEC task, which is a memory task with 2 different conditions, so a 0-back and a 2-back. The 0-back is a very easy task, or relatively easy task. Again, healthy patients, healthy participants. So the 0-back is just press the button when you see the letter X. The 2-back is press the button if you see the letter that was presented to previous, 2 trials previous. Then with all that information, we defined our target, again, based on the resting state that I've discussed before. And session 2 then involved the actual TMS-MRI. So we determined the motor threshold, we guided the coil placement via neuronavigation and delivered TMS at rest during the easy task and during the complex task. We applied it at 10 Hertz triplets at 100% of the resting motor threshold. So this setup let us compare neural responses across cognitive states and to better understand these state-dependent effects. So we decided to specifically control for stimulation onset timing in order to investigate these interactions. So we either stimulated 250 milliseconds before stimulation onset or 150 milliseconds after stimulation onset. So either before the stimulus was even perceived or processed and just after. So this is a very small time scale, and this is a time scale that's not available in fMRI. This is only available in TMS. However, we can measure the effects of these small differences with fMRI. So for the analysis, we looked at a relatively complex contrast, which is between the top and the bottom here. Basically, can summarize it as effectively interrupting memory retrieval and ineffectively interrupting memory retrieval based on the timing. So we can see here that the brain activation is different when we compare effective versus ineffective TMS during the two-back task. So only when the brain has to be fully engaged to process. So in red and yellow, you see the regions with increased activation, mostly in the left DLPFC, as you can see there in the IFG, around the area that we stimulated at. And in blue and green, we see actually decreased activation, including the SGACC, as you heard before, linked to clinical response. So delivering TMS at the right moment within the task leads to more engagement of the target and greater suppression of areas associated with depression. This kind of supports our idea about state-dependence efficacy. So just want to summarize what I've now told you in a very rapid way, I feel. Is first of all, we have some clinical trial insights where the SGACC engagement during stimulation actually predicts our clinical response, and that the circuit engagement that we see there might be a promising biomarker for treatment efficacy. We also see that there is something going on with dose dependency, and that the individual dose response profiles highly vary across individual participants and patients. So healthy and patients actually showed very similar differences. So dosing based on the M1 region might not be optimal, and we might need to personalize that. Then I also have shown you state dependency effects, where the TMS effects really vary depending on the cognitive state during stimulation, and that combining fMRI with task-based interventions will allow us to see the real-time circuit validation there. So with this talk, this is my last slide, I wanted to show you that concurrent TMS fMRI in clinical research, and now I've only shown you depression, but I would really encourage you to also try it in different psychiatric disorders or any other clinical way. We can show that circuit engagement matters. So there is something meaningful in the fMRI pattern that we find when we stimulate. The dosage matters and the state matters. So these are three big takeaways from the clinical trials that I've run. And so overall, TMS fMRI actually enables us to look further into these mechanisms that lie underneath TMS. And we can maybe look further into a biomarker for treatment response and make sure that the people that do not respond now can respond to the treatments as well. We can personalize it in many different ways, and when we do a TMS fMRI session, we can actually validate or try and approach a validation of the right target circuit engagement there. Good, I put a lot of information, I feel, in a very short amount of time, so if you have any questions after, feel free. But this was my presentations for so far, and I would like to thank my team in Sunnybrook and also my team in Vienna, and greetings from Martin. He would have loved to be here, but sadly it's just me. Thank you.